Welcome to my YouTube channel. Today's video, we shall be looking at the anatomy of the carpal tunnel. The carpal tunnel is an osteofibrous tunnel that is located at the anterior aspect of the wrist. So if you are coming across my channel at the first time, don't forget to subscribe so that you get notification when I upload video on human anatomy. Without wasting much of our time, let's dive into the class. The first thing is the introduction. What is carpal tunnel? Carpal tunnel is a narrow passageway that is found or located at the anterior aspect of the wrist. It is a narrow passageway that is found or located at the anterior aspect of the wrist. It serves as an entrance to the palm. It serves as an entrance to the palm because it is located here, anterior wrist. So for some structures, it is not all the structures that enters the palm that passes through the carpal tunnel. So for some structures to enter the palm, they have to pass through the carpal tunnel. So it serves as an entrance to the palm. So it serves as an entrance to the palm for several tendons and median nerve, because it is only the median nerve that enters the or that passes through the carpal tunnel, and flexor tendons, particularly the superficial flexor tendons and the deep flexor tendons. But it is not all the superficial and deep flexor tendons of the anterior compartment of the forearm that passes through the carpal tunnel to enter the hand. It's not all of them. So as you proceed, you will see those tendons of the superficial and deep flexors that enters the palm by passing through the carpal tunnel. You get. So it serves as an entrance to the palm for several tendons, muscular tendons, and median nerve. So as you proceed, you get to know which branch of the median nerve. How does the median nerve enters the carpal tunnel to exert its sensory and motor activities on the hand? So let's proceed. So the introduction of the carpal tunnel, which I've said previously, it is a narrow passageway that is located or found on the anterior aspect of the wrist. If you want to indicate the location of the carpal tunnel, you have to look at the distal crease of the hand. Of the wrist, the distal crease of the wrist. This crease, this is where the carpal tunnel is located. Exactly here. This is the distal crease. You get. So it serves as an entrance to the palm for several tendons and median nerve. That is the introduction of the carpal tunnel. The next we shall be looking on to is the layers. The layers. The carpal tunnel has two layers: the superficial layer and the deep layer. Superficial layer and deep layer. The deep layer and the superficial layer forms the layers of the carpal tunnel. Now let's start with the superficial layer. The carpal tunnel is formed by two layers. Before we start from the superficial layer, it's formed by two layers, which I've said previously: the superficial layer and the deep layer. It is formed superficially by the flexor retinaculum, and the deep by the carpal arch. Now see it here. This diagram here depicts the boundaries, the base, and the content of the carpal tunnel. Now the superficial layer of the carpal tunnel is being formed by the flexor retinaculum or the transverse carpal ligament. Now watch. This is the superficial layer, which is being formed by the flexor retinaculum. Retinaculum. And the deep layer is formed by the deep carpal arch or the carpal arch per se. Look at the carpal arch. The carpal arch forms the base and the sides of the carpal tunnel. Look at it here. This blue marker or ink indicates the carpal arch, which forms the deep layer of the carpal tunnel. Now, the carpal arch is usually concave. It forms a concave surface. And what is a concave surface? A concave surface is a surface that is hollow or shallowed. It can be called the female surface. This is a concave surface. It is hollow. You can see it. It forms a what? A concave surface, which is converted into a tunnel, an osteofibrous tunnel, by the overlying flexor retinaculum. And this can be called the transverse carpal ligament. The flexor retinaculum can be called the transverse carpal ligament. It is this connective tissue that converts the carpal tunnel, the carpal arch, you get, into an osteofibrous tunnel, because it overlies it. You get, it overlies it, converting it into a what? A carpal tunnel, which is an osteofibrous tunnel. Now watch, this is the carpal tunnel. Inside here is the what? Carpal tunnel. So this can be called the transverse carpal ligament. The transverse carpal ligament. It can be called the transverse carpal ligament. It converts the carpal arch, that is the deep carpal arch, into an osteofibrous tunnel. You get, and that is the carpal tunnel. This is the deep carpal arch, which is usually concave. It forms a concave surface, which is then converted into a tunnel by the flexor retinaculum, which can be called the transverse carpal ligament. Here is the carpal tunnel. So let's indicate it. Inside here is the carpal tunnel. This is the carpal tunnel. That is the what? The carpal tunnel. Now, let's discuss the carpal arch. The carpal arch. The carpal arch, as I've said previously, it forms a concave surface on the palmar side. It forms a what? A concave surface on the palmar side. And it forms the base and the side of the carpal tunnel. You get? So it forms the base and the size of the what? Of the carpal tunnel. It is being bounded laterally or formed laterally by, so it's bounded or formed laterally by the scaphoid and the trapezium tubercle. You get? Because this is the scaphoid bone. The scaphoid bone. While here is the scaphoid tubercle. The scaphoid what? Tubercle. So the carpal arch is formed laterally by the scaphoid and the trapezium tubercle. And it is formed medially by the hook of hamate and the pisiform. So the carpal arch is bounded laterally or formed laterally by the scaphoid and the trapezium tubercle, and formed medially by the hook of hamate and the pisiform. Now watch. These are the proximal rows of the carpal bones. These are the proximal rows of the carpal bone. We call that the carpal bones are arranged into two rows: the proximal row and the distal row, from the lateral to the medial side. Now this is the scaphoid bone. You get. Now here is the lunate. This is the what? The triquetra. You get. The triquetral bone, while this is the pisiform. These are the proximal rows because there is a mnemonic to remember the carpal bone. She looks too pretty. Try to catch her. She looks too pretty. She, S, look, L, too, T, pretty, pisiform. So they are the proximal rows. You get. Why the distal row is try to catch her. Try, trapezium. You get. Two is what? Is trapezoid. Ha is now hamate and capitate. Do you get? So those are the distal rows of the carpal bones. These are the proximal rows. But the carpal tunnel involve the both row because there is an attachment of the what? Of the flexor retinaculum on the both bones that forms the proximal row and the what? And the distal rows. Okay? Now, these are the everything concerning the carpal arch. Now, the next is the flexor retinaculum. The flexor retinaculum. The flexor retinaculum is a what? Is a thick connective tissue that forms the roof of the carpal tunnel. Is a what? A thick connective tissue that forms the roof of the carpal tunnel. You get. And this flexor retinaculum, what does it do? It converts the deep carpal arch into a tunnel. It converts the deep carpal arch into a what? A tunnel. By doing what? By bridging the space between the lateral and the medial aspect of the arch. You get. So the flexor retinaculum converts the deep carpal arch or the carpal arch into a tunnel, which is the carpal tunnel, by bridging the space between the medial and the lateral aspects of the what? Of the carpal arch. That is what it does. And this flexor retinaculum, what it does again is that it plays an important role. You get, in formation of the what? Of the carpal tunnel. It plays an important role in formation of the carpal tunnel. Then it tends to span between the medial and the lateral aspect of the carpal arch. That means it spans between the scaphoid and the trapezium tubercle laterally and the hook of hamate and the pisiform bone medially. That is another thing it does. So the summary is that the flexor retinaculum converts the carpal arch into a tunnel by bridging the space between the medial and lateral aspect of the arch. That is what it does. What it does. So it is a what? A thick connective tissue that forms the roof of the carpal tunnel. Now, there is a superficial slip of the flexor retinaculum which is called the volar carpal ligament. Here is the superficial slip of the flexor retinaculum. Superficial slip of flexor retinaculum, which can be called the volar carpal ligament. The volar carpal ligament. So that is all about the flexor retinaculum. Yes. All about the what? The flexor retinaculum. It is a thick connective tissue that forms the roof of the what? The flexor retinaculum. Now let's go to the content. The content. The content. What are the content of the carpal tunnel? Number one is that the carpal tunnel contains 9 muscular tendons. Nine muscle tendons. It contains 9 muscle tendons, and 2 is the median nerve. Okay? Now, pay attention here. It has 9 muscular tendons. You get? Among those 9 muscular tendons, those tendons are covered by a synovial sheath, a peculiar synovial sheath for their tendons. Now watch. This is the 4 tendons of the flexor digitorum profundus. And this is the 4 tendons of the flexor digitorum superficialis, while this is the tendon of the flexor pollicis longus. And here is the median nerve. So it has totally 9 tendons. But the 8 tendons of the flexor digitorum superficialis and profundus are covered by their own synovial sheath, whereas the tendon of the flexor pollicis longus is covered by its own synovial sheath. Permit me to take that again. The 8 tendons of the flexor digitorum profundus and superficialis are covered by their own synovial sheath, while the tendon of the flexor pollicis longus is covered by its own what? Synovial sheath. Now watch. This is the what? The tendon of the flexor digitorum profundus. While this is the tendon of the flexor digitorum superficialis. Now, this is the tendon of the flexor pollicis longus. Tendon of flexor pollicis longus. Why this is the median nerve. Okay? Now, you have to understand that at the level of the forearm, you get, the median nerve gives a cutaneous branch, which is called the palmar cutaneous branch. The palmar cutaneous branch of the median nerve, which arises in the forearm to exert its cutaneous innervation at the level of the palmar skin in the palm, does not pass through the carpal tunnel. It descends superficially at the flexor retinaculum. That is an important clarification. So any lesion or damage of the median nerve at the level of the carpal tunnel will not affect the sensory function of the palmar cutaneous branch of the median nerve, because it arises in the forearm to travel superficially at the flexor retinaculum. It does not pass through the what? The carpal tunnel. That is an important clarification. The palmar cutaneous branch of the median nerve, which arises in the forearm, does not pass through the carpal tunnel. It descends superficially to the flexor retinaculum. That is an important clarification. Now, the median nerve at the level of the carpal tunnel. Recall that once the median nerve passes through the carpal tunnel, it bifurcates into two. It terminates by bifurcating into two terminal branches: the palmar digital branch and the what? The recorded branch. Now, the recorded branch supply to the what? Muscles of the terna eminence. Supplies to the terna eminence region, those muscles over there, you get. While the palmar digital branch gives a cutaneous innervation, you get, to the palmar skin, the dorsal nail bed, and the lateral 3.5 digit. It also gives a motor innervation to the lateral 2 lumbricals, you get. So to tell you that any lesion of the median nerve at the level of the carpal tunnel will implicate carpal tunnel syndrome, and the motor and the sensory branch of the median nerve at the level of the hand will be damaged. That is the recurrent branch and the what? The palmar digital branches, you get. There will be loss of motor innervation to the muscles of the terna eminence, leading to what? Terna eminence muscle wasting or atrophy. Okay, so that is all about the what? The activities of the median nerve at the level of the what? Of the carpal tunnel. Now, important to note, there are structures that transverses the what? The flexor retinaculum to enter the hand. It is not all structures that passes through the carpal tunnel, you get. Now, recall that this volar carpal ligament, there is a space here, you get. It gives the passage of the ulnar vessels. The ulnar vessels passes through the what? This space that is formed by the superficial slip of the flexor retinaculum, which can be called the volar carpal ligament. But then there are structures that transverses or descends what? Superficially to the flexor retinaculum. Any structure that descends superficially to the flexor retinaculum does not pass through the carpal tunnel, you get. And any structure that passes deep to the flexor retinaculum passes through the what? The carpal tunnel. And what are those structures that could pass or descends superficially to the flexor retinaculum or the transverse carpal ligament? We have the ulnar artery, the ulnar nerve, the palmar cutaneous branch of the median nerve, the palmar cutaneous branch of the ulnar nerve, the palmar or the superficial palmar branch of the radial artery, the tendon of the palmaris longus. All these structures, muscles and nerves and artery, passes superficially to the flexor retinaculum. So they do not pass inside the carpal tunnel, because any structure that passes deep to this ligament or this connective tissue must enter the carpal tunnel. Now, what are the structures that passes deep to the flexor retinaculum? We have the what? The tendons of the flexor digitorum profundus, the tendons of the flexor digitorum superficialis. We have the median nerve, and we have the what? The tendon of the flexor pollicis longus. So these structures passes deeply to the what? The flexor retinaculum. That means they enters the carpal tunnel. But the structures I mentioned previously do not pass to the carpal tunnel, because they descend superficially to the what? To the flexor retinaculum, you get. So sometimes you could see it in medical board exam. Which of these structure does not pass through the carpal tunnel, it means that they descend superficially to the flexor retinaculum, which I have just mentioned previously here. The ulnar artery, the ulnar nerve, the palmar-cutaneous branch of the median nerve, the palmar-cutaneous branch of the what ulnar nerve, the superficial palmar branch of the radial artery, and we have the palmaris longus, the tendon of the palmaris longus muscle. These are the structures that descend superficially to the flexor retinaculum. They do not pass through the carpal tunnel, because had it been the descends deep to this connective tissue, it would have passed through the what? The carpal tunnel. The descend superficially. So that is all about that. Now let's dive into the what? The clinical relevance. So the content is the 9 muscle tendons and the median nerve. Okay? Clinical relevance. Clinical relevance. The most pronounced clinical relevance of the carpal tunnel is the carpal tunnel syndrome. The carpal tunnel syndrome occurs as a result of compression of the median nerve at the level of the carpal tunnel. It is the most commonest mononeuropathy. And once there is a compression of the median nerve at the level of the carpal tunnel, it implicates carpal tunnel syndrome. What could lead to the compression of the median nerve at the level of the carpal tunnel? We have tightened ligament and tendon sheath. The tightened ligament and tendon sheath or tendinous sheath could lead to the compression of the median nerve at the level of the carpal tunnel. And once this is implicated, it will lead to what? Wasting or atrophy of the muscles of the tendon eminence, because the recurrent branch of the median nerve as one of the terminal branch of the median nerve at the level of the palm is what? Is damaged. And also, there will be loss of cutaneous innervation at the palmar skin, the dorsal nerve bed, the lateral 3.5 digit, and also the paralysis of the lateral two lumbricals, because the palmar digital branch of the median nerve as one of the terminal branch of the median nerve is lesioned. You get? So there will be what? A whole lot of dysfunction, because the motor and sensory branch of the median nerve at the level of the palm or the hand is lesioned, except the palmar-cutaneous branch of the median nerve, which arises in the forearm, descends superficially to the what? To the flexor retinaculum to enter the hand. It will not be damaged because it does not pass through the carpal tunnel. It descends superficially to the flexor retinaculum to enter the hand. You get? So that will be implicated as a result of the carpal tunnel syndrome, because the median nerve is lesioned or compressed. When it's compressed, it is lesioned already. Those recurrent branch and the palmar digital branch will be what? Will be damaged. Their sensory and motor activities will be compromised. So that is all about the carpal tunnel syndrome. And recall that if carpal tunnel syndrome is left untreated, it could be more severe. You get? Those muscles will be completely paralyzed and atrophied. So medication is important. So that is all about the what? The carpal tunnel syndrome. Thank you so much